Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Michelle Hedding. Michelle is the Spiritual Care Coordinator at Washington Hospital. She received her master's degree in spirituality and culture from the Sophia Center at Holy Names University. She is a registered nurse with her master's in nursing. Michelle is also a certified hospice and palliative care nurse. She worked at Washington Hospital as a staff nurse prior to her current role as the Spiritual Care Coordinator.
So the name of the presentation is It's Your Choice. If you don't make a choice, it's not your choice, right? So that's why I want to talk to you guys tonight about why it's important to make a choice and how to make that choice. So the other thing that I want to start out by saying is that a lot of times, I don't think you guys, because you decided to come to this presentation, but a lot of people hear advanced directive, and they think that we're talking about dying. What we're actually talking about is living and how you want to live. So live means to learn about end-of-life services and care, to implement plans and that would honor your wishes, voice decisions to your family, friends, and healthcare providers, and engage in personal and community efforts to improve end-of-life care. And by being here tonight, each of you is doing that. You're going to become ambassadors. That's how I'm going to frame this. You're going to all learn tonight, but then you're going to go tell everybody that you know about why this is important. So you guys are engaging right now. So thank you for being part of the team. So a roadmap for tonight, just so that you guys have a sense of where we're headed, what we're going to cover. Why is it important? That'll be the first part. Then we're going to talk in more detail about advanced directives, how we even came about in the United States, what the forms look like, what's a pulsed form, and some of these things you may already know, so if it's a review, that's okay. But I'm going to go into some pretty strong detail of the form that's in the back of the packet that you got tonight, going through exactly how you would fill it out. Then I'm going to talk some about palliative care and hospice, which aren't necessarily directly at this time involved in your advanced directive, but it's a part of the spectrum that we're on. At some point, it may be part of the services that you need. So I want people to have some understanding of what that means. And then there'll be ample time at the end for questions. I have some question time built in the middle of the two topics too, just to have you be able to ask questions when the ideas are on your head. So why? Why is it so important to have these conversations? I have two brief stories that I want to share, personal stories. So go backwards in time to 1981. 36-year-old man has a tumor that's found in his brain. The family isn't given a whole lot of decisions. The surgeon says, we're going to go in and see what's going on. 2 weeks later, he dies in the ICU. This was in 1981. I can say that hospice wasn't very common in 1981. Advanced directives were not really written into law yet. And so that was how that story unfolded. Fast forward to 2001, 81-year-old woman with Alzheimer's disease, not very progressive Alzheimer's disease, but starting to progress, comes down with pneumonia. And that family had a discussion with Nana and said, what would your wishes be should something like this happen? And the decision was made not to treat the pneumonia in line with Nana's wishes. And Nana, 3 days later, peacefully passed in an inpatient hospice unit. This was on the East Coast. And everyone's wishes were honored. So like that graphic on the first slide, you can go in lots of different directions, and we're not here to say which way you should go, but we want you to know what your options are. So here's some statistics that sometimes speak louder than words that I can share with you. This is a survey of the California Healthcare Foundation, who also had a hand in making that video. 60% of people say that making sure their family is not burdened by tough decisions is extremely important. And 56% have not communicated their end-of-life wishes. So almost the same number of people that think it's important to haven't. 80% of people say that if they're seriously ill, they would want to talk to their doctor about end-of-life care. And only 7% have had that conversation with their doctor. So this graph pretty much talks about the same thing, that there's a high proportion of folks that are very interested in having the conversation. And then the second one, the yes there, is how many people actually have an advance directive. So without any shaming, I want to see a show of hands. You're in a safe space. Can I just see a show of hands for how many people have already completed an advance directive? Okay. Okay, and I'm in the same boat. What the lady up front said is that she's got it filled out, but she hasn't had it signed yet. And I'm actually in the same boat, so I can stand up here and be advocating for this, and I still haven't gotten mine witnessed. So I can listen to my own words as well. So hopefully tonight that will push us all into that next step. And then this is another interesting thing, because this can also be part of the conversation that you have with your loved ones. 70% state that they would prefer to die at home. And I've seen statistics that say approximately 70% actually die in the hospital. So if you don't say that to your family member, and again, no agenda, whatever you wish is what should be carried out, but if you don't say that, and that family member calls 911 and you're really sick, you may not get your wish. So these are some of the things to consider when you're making these decisions. And regardless of which path we take to our final destination, it's really important to plan. These are some graphs that show, the top one is where cancer is the normal curve, where you would kind of be going along and then you would have a decline. Or you could have something like COPD, CHF, things that, you have some exacerbations, you get worse and then you get better. So this is the kind of the dipping and then you get to the end. Or a lot of times if we've lived a long life, we may just start to have frailty, dementia, and just kind of fade off. Whatever the path is, we don't know what our path is going to be. If we don't talk about how we want the end to look, then we aren't going to have that choice. So this is something I got. This doctor is an anesthesia and pulmonologist, anesthesiologist, and a critical care fellow. So he's in environments where he sees people that are really sick, and he came up with these 4 things that everyone should know about end-of-life planning. To know that it's okay to talk about it right now, when we're healthy. Like in that first clip, it's like when we're really sick and we're in the ER or we're in the ICU, not going to be the best time to talk about it. So right now, when you're healthy, sitting here in a seminar is the best time. Number 2, know who your proxy is, who your agent is, who you want to be your voice when your voice isn't able to speak. And a lot of people, I mentioned this at this point, it's not always going to be the person that you might think that it is. Sometimes you may not choose a family member, and that doesn't mean that in any way that you don't trust that family member. It just means that maybe you don't want them to be burdened with that decision. The example I give is that there's a couple nurses that I know that have actually chosen each other. They didn't want to put their spouse through that decision-making process, and they felt that that would be a better thing. So it's up to you, but just know that you need to know who the right person is to be the one speaking on your behalf. Know that you can change your mind. You can always change your mind. That's the other thing, that sometimes people think I put it in writing and then what's going to happen if something changes. You can always change it. Right now we're sitting here, we got up, we came to this seminar, we're all pretty healthy. So we may have a decision today that would be different down the road when we get a diagnosis that might change our opinion about things. So always can be changed. And then know to ask questions. You may not understand some of the words in the document, which is why I'm going to spend some time really going through the document. You may not understand some of the medical treatments that you might be able to receive or not receive. So ask people that you trust what things mean before you make decisions. So this is the dry, boring slide. The brief history of advance directives. They've been around for over 50 years. It used to be called living wills, which some of you probably have heard of that. In 1976, California state law supported advance directives, and eventually all states adopted such legislation. In 91, it became federal law, the Patient Self-Determination Act. So if any of you have gone through our ED, we're required by federal law to ask if you have an advance directive. You're not required to have one, but we have to ask whether you do. And then we also have to let you know that the information, we provide you with information on how you could obtain one if you wanted to. So that's federal law. And then in 2001, a law was passed in California, and after that in many states, putting into effect this physician's order for life-sustaining treatment. I'll go over that briefly later in the seminar, but what that is a one-page document that really clearly says, if my heart stops, this is what you should do. It's much more boiled down than the advance directive. So the basics. It's really quite simple, 3 bullets. There's a lot of different options for forms, and I'll show you some images of different forms, and folks have heard of different forms, but really the form isn't as important as what you're putting on the form. You only need 2 witnesses. If you have 2 neighbors, they can sign it. 2 friends from church, they can sign it. Just saying that you are who you say you are. They're not legally bound to anything. They're not becoming your healthcare agent. They're just saying, yep, you're who you say you are. Or you can get a notary, but you don't need to go to a lawyer. And some people think that you do need to go to a lawyer. For this document, you don't. 2 witnesses or a notary, and you're done. And I explained a little bit already about how the POST is different. The advance directive is mainly designed to name the agent that would speak on your behalf, and then you can also have alternate agents, and then to give some guidance as to what your wishes would be at the end of life. But it's not always, you can decide the level of specificity, but it doesn't have to be completely specific. And the POST is much more specific, and I'll show you that form and explain that. So these are some of the forms. This is the front of the one that we have in the packet. The last pages in your packet are this form. And then this is another basic form. Some of the doctors in the township hand this one out, so I've seen that floating around. That's an image, a little screenshot of the POST form. And then 5 Wishes is another document. How many of you have heard of 5 Wishes? Yeah. A handful. It's put out by a group called Aging with Dignity. I think I got that right. And they're available online, but they're for cost. You have to buy them. I think they're $5 each, something like that. They're different. They go into a lot more detail. The form that we have is a little bit more legal sounding, and the 5 Wishes goes into some more of the emotional, psychological, spiritual aspects. It depends. Some people really like it. Some people feel that it's a little bit too wordy, but they're all the same thing. It's just a different cover, basically. So those are some of the options that are out there. Like I said, this is the one that we pretty much use here, and that's the one that I will be going through with you right now. So that first page just explains the instructions. It's the second page that's up on the screen right now. Can you guys all see? Well, you have it in front of you too. So at the very top, what you're doing is designating the agent. You're naming the person that we would call when we need to ask questions and you can't answer them. And then you have the option of doing 2 alternates. And all you do is fill in their information, their name, address, phone number. Put as much detail as you can, because obviously you want us to be able to reach this person. But yeah, you can do as many as 2 alternates. And then this last section is to basically authorized to make decisions. Yeah, this is where you can put any exceptions, things that you don't want your agent to be able to make decisions for. So if you want them to make all decisions, then you leave that blank. But if there's anything that you don't want them to decide, then you can specify that there. The next page, so this is talking about when the agent's authority becomes effective. And for most folks that are walking and talking and can make their own decisions, their agency wouldn't come into play until you were no longer able to. In a situation where maybe someone knows they still have the capacity to make the decision and fill out an advance directive, but they know that they're starting to decline. So they may want someone to be engaged right now as their agent. So you get to make that decision. And this top one would be that when you're unable to make decisions or takes effect immediately. Does that make sense? Okay. And then this next section talks about the agent's post-death authority. So again, you can leave it blank and that doesn't really give them any particular authority, but if you would like them to make a decision to have an autopsy or something after your death, then you can put that in that area. And that last section is for nomination of a conservator. If for some reason the agent is unavailable or unwilling and no one is stepping up to speak for you, you could state that you would want a conservator to be named on your behalf. This is a lot of detail, but I really wanted you guys to have a full understanding of what the form can do. A lot of the sections are optional. So part 2 is your end-of-life decision. So the top one would be that if I was in a situation where it looked like my prognosis was not looking good, I would not want choice not to prolong life. So that's if there's an incurable, irreversible condition, something where the doctors, to the best of their ability, don't feel like I'm going to come back from, that you wouldn't want us to do a ton of heroic measures. Or the second choice would be prolong life at all measures. And that is the choice. You get to make that choice. The thing as healthcare providers is that we feel uncomfortable when you haven't stated what your wishes are, because our default is going to be to do everything. And if that isn't what you want, we really need you to have spoken up and have stated that. And then the next section talks about relief from pain. And I can't imagine anyone not wanting to be relieved from pain, but if you have a strong feeling about pain relief, you can state that there. And then the last section, and you can add additional sheets as you would see fit, are just for any other things that you would want us to know. So third section is about organ donation, totally optional section, but that allows you to state whether and what parts you would want to be donated. And you don't have to fill that in. But again, if you have strong feelings about that, it's in your best interest to fill that in. Part 4 is a place for you to put in your primary physician's information. And then a secondary, if for some reason your primary doctor is on vacation, you can put in a secondary doctor, someone who would know you well. This could really come in handy if you're showing up in a place where you're not known as well. So that we can call your doctor and talk to the person that knows you. And then the last part is just your signature, name, address, and then the last section is for the witnesses. The first and second witness, again, the folks that can't witness for you would be obviously the person that you're naming as an agent. Anyone that is part of your healthcare team, that would be a conflict of interest. And generally, family members shouldn't be witnesses because that can also be kind of a conflict of interest. So really just friends, neighbors, someone that just wants to do you a good favor of just witnessing that. So the last page is for if you get it notarized. And then at the very bottom, if you happen to be in a skilled nursing facility when you're filling this out, which I'm guessing that none of you are residents of a skilled nursing facility because you've come to be with us tonight, an ombudsman needs to be part of the signatory on that as well. So, do you guys have any questions about advanced directives? I know I covered a lot there. The other thing to point out, I think there's a flyer that you'll be able to pick up at the end. Christy, who was kind enough to introduce me at the beginning, is available to make appointments with, to have a fuller conversation. We aren't going to have time in this context to have the full conversation, but she can make appointments to do that with you and answer in-depth personal questions. So I wanted to talk a little bit more about the post, as I promised I would. I put this one in there just so that you can see it's a pink copy, that it should be pink, and that's so that we can see it. We recommend if people have a post filled out that they put it on their refrigerator. It's enforceable in an ambulance. If you call 911 and you have a post and they see it, they have to carry it out. The little symbol that's up in the corner, that's the Emergency Medical Association. They were instrumental in the legislation that was passed to have this happen because sometimes you're in the hospital and you want to be a do not resuscitate. And when you leave the hospital, unless you have a post, you are no longer a do not resuscitate. And that happened to me when I was a bedside nurse. I had a patient and I gave a report to the ambulance driver and said, well, they're a DNR. And he said, well, where's their pulse? And I said, they don't have a pulse. And he said, they're not, I mean, they will be when they get to where they're going, because they were going to a skilled nursing where they had an order that a doctor could write there. But the cool thing about a pulse is that it's portable. Unlike an advanced directive where we recommend everybody over 18 should have one. If you're under 18, then your parents are going to be making decisions. If you're over 18, even if you're young and healthy and you're 18, something could change on a dime and you may not be able to answer questions. So the difference with a pulse is that we recommend them for folks, the kind of litmus test that I've been taught is if you wouldn't be surprised if the person were to be deceased in a year. And that isn't a hard and fast rule, but it's more for someone that is either frail, that is either with a life-limiting illness of some sort, someone who you're more conscious of their mortality, I guess would be a way of putting it. So someone where you would want to be clear in what their wishes were. So the next slide is a little bit bigger blown up, and it's the most recent version of it, which is why I included it. So the very top section, section A, is really straightforward. If my pulse stops and I'm not breathing, do I want resuscitation or do I want to allow a natural death? It's an either or. Because at that point, if your heart has stopped, you're going down a two-way, you know, there's two paths you can take. And so that's how that first section works. The second section talks about what level of treatment you would want. So the top one is full treatment, which is just what it sounds like. We would do everything possible, whether that's medication, whether that's compressions, intubation, whatever is possible, we would do that. Selective treatment is sort of the middle road. Lots of focus on comfort, but probably not doing things that are really burdensome. Trying to avoid ICU transfers, but doing that if it was necessary. And then the bottom one is more comfort-focused treatment, which is sort of, if you've heard of hospice, and we'll talk more about that in a little while, it's sort of more along those lines. You're coming towards the end, and you really don't want us poking and prodding and doing a whole lot to you, so then you would choose comfort. The cool thing about this new version is that there's a box you can check a trial period of full treatment. So I'll use myself as an example. I'm a pretty healthy person. I don't expect that I'll die in the next year. I don't know because I'm not in control of that. But I would want to attempt resuscitation. But if I then end up staying in the ICU for many weeks on end and I'm starting to get worse and it doesn't look like I'm getting better, I'm going to check the trial period of full treatment. I'm not going to want that to go on forever. This is my personal feeling. So that's where that trial period of full treatment can be useful, because you're like, yeah, give me a shot. Try to get me through this. But if it's not looking good, then you get that out of saying, don't do it forever. And the old forms didn't have that nuance. And then under selective treatment, this other box, it says to request a transfer to the hospital only if comfort needs can't be met in the current location. So again, that's optional. You can check that box or not check that box. And then section C talks about artificially administered nutrition. So you have the choice of long-term nutrition through feeding tubes. So that would mean potentially a tube in your nose or a tube in your belly if it's longer term. Trial period of artificial nutrition. So maybe that would mean a tube in your nose, and then if you're starting to get better, we can take it out. Or I just don't want artificial nutrition. So you get to make those choices. And then the last part is just filling in whether you have an advance directive, who your agent is, the signature of your legally recognized decision maker, because even if you don't have an advance directive, which obviously I'm recommending that you should have one, that you can still have someone that you're saying is the person that is your legally recognized designated decision maker. What I think about these two forms is they work really well hand in hand. They're each by themselves, they aren't really complete. The cool thing about the advance directive is that you name the person that would speak for you, and then the post gives a lot more clear, detailed information about what your actual wishes are when it comes to the end. Okay, so the differences between the advanced directive and the pulse, just to kind of boil it down, advanced directives are general instructions for the future and need some interpretation. There's a little bit of grayness in the advanced directive. It's not always going to be spelled out. You can spell it out in as much detail as you want, but there's still going to be some room for interpretation. Needs to be retrieved. It's not something that, that you would carry around. I don't know anyone that carries one in their glove box. And there are many different forms signed by the patient and by witnesses. So the pulse is talking about right now, like you're in a medical situation and how should we react right now. It stays with the patient, so meaning if you're at home, it would be on your refrigerator. If you're somehow in a skilled nursing facility, there'd be a copy there. If you come to the hospital, you bring it with you. So it's a portable document, as I had said before. And then the other good thing about the pulse is that it's a single standardized form that's signed by the patient and the doctor. It's a legally bound doctor's order. So that just kind of gives you, it's not that either one is better, but they just have different traits. So that's why I think it's important if you're in that phase of your life where, again, you have a life-limiting illness or you're frail or chronically ill, that you consider having both. So this is just a graphic, again, just to sort of talk about the continuum of these two documents that we've talked about. You notice the thing that's constant throughout the whole thing is the conversation, talking about it, making it part of your conversation with your loved ones so that there's not a guess. When the hardest thing is when I'm in the ICU talking to a family and I ask the question, have you ever talked to mom about what her wishes are? And if the answer is no, that family member is having a hard time making a decision because they don't know. They can make some guesses, but they would feel better. It's a gift you can give to your family to be able to have this conversation. So the conversation happens the whole time. From 18 on, we recommend completing the advanced directive, updating it as necessary, and then if there's a serious or chronic illness at any age or progressive illness, recommend filling out the pulse. And then our hope is that in the end, it means your treatment wishes are being honored. So I'm gonna go into our hospice and palliative care section. How many of you have heard of hospice? So the majority of folks in the room have heard of hospice. Just to give you some history, it's not that long that it's been around. It was really created in the 60s in London as programs to care for the dying. In the Middle Ages, actually, the word hospice was a way station for pilgrims on the way to the Holy Land. So it's taking care of people that are on a journey. And that was the philosophy of Dame Cicely Saunders, who founded St. Christopher's Hospice. She viewed life as a journey and felt that hospice was to support people on that final journey in life. The first U.S. hospice was in '74 in Connecticut, the Connecticut Hospice, and in the '80s, hospice became more widespread in the United States. Hospice care, the definition would be that it's created to care for patients with a limited life expectancy, and that's defined as 6 months. So that to be on hospice care, you need to have a prognosis from a doctor that says you're not expected to live more than 6 months. It provides comprehensive support of the patient's whole person, their body, their mind, their spirit, and also supports the family in the process of dying and even after death. In most hospices, follow a patient's family for 13 months to get them past that first anniversary to help with any bereavement support. So the myths of hospice, I'm just going to put this one out there. Everyone hears hospice and they think death. And that isn't always the case, especially if you get into hospice before you're super, super sick. What it does is it helps, it's a service that helps to support the quality of life. It's not about how many more days can we squeak out, it's about how many good days can we have, how many days where we're home in our environment where we love to be with our pets, looking out at our garden, whatever the environment is that you feel the happiest in, being there and having the best life that you can for whatever time you have. Because that isn't really easy to pinpoint. No one can really define that. So I think of hospice as just a container that gets created to hold everyone, the patient at the center of that container, but everyone that cares about that patient being held. This is a quote that I love that to me just summarizes the philosophy of hospice, and it's from that founder that I talked about, Dame Cicely Saunders. You matter because you are you. You matter to the last moment of your life, and we will do all we can do, not only to help you die peacefully, but to live until you die. I couldn't have come up with better words to describe what I think hospice can do for you when that time comes. So palliative care, how many have heard of palliative care? Okay. A couple less hands went up for that, and that isn't surprising. It kind of grew out of the hospice movement. The first hospital-based palliative care programs came around in the late 80s, so a little bit after hospice started to really pick up in the United States. Palliative care is that specialized medical care for people living with serious illness. So you don't see anything there about a 6-month prognosis. It's just someone with a serious illness. That could be lots of illnesses. It could be many different chronic illnesses. I mentioned before CHF, COPD, and I'm using acronyms. I just realized you guys were talking about the medical terms, congestive heart failure or chronic obstructive pulmonary disease. Diseases that you can live with for many years, but you often have a lot of symptoms related to them. So it's an approach that focuses on, again, improving the quality of life for the patients and the families that are dealing with life-limiting illness. A focus on relief from suffering, provided alongside curative treatment. So there's a chart that I'll come up with that'll kind of show the difference between hospice and palliative care. And a lot of times with hospice, that is a decision to shift away from curative and to focus more on symptoms and comfort. But the difference with palliative, because it can be at any point in the disease process, a lot of times you can still be getting some treatment, curative treatment. And the best way to think of palliative care is that it's an extra layer of support. You have all your other doctors, a doctor for every part, right? You've got your kidney doctor, your lung doctor, your GI doctor, you've got all those doctors, but then palliative care is this extra coverage. It's extra help to support all those other parts that are important. Your spirit, your social situation, and the symptom management piece is also important. So palliative care is not only for cancer patients, for old people, for end-of-life care, or hospice. End-of-life care is a really specific type of care, right? Around that is hospice, which is even more specific, right? 6-month prognosis. Palliative care kind of encompasses all of that. Palliative care, again, can come in at any point in the disease process. And a lot of the same principles of hospice are carried out in palliative care, but the difference is that you're not right at the end. You still have a lot of, yeah. So this is just to sort of summarize, very similar, right? Comfort as the goal is true for both hospice and palliative care. Interdisciplinary, I didn't talk that much about that, but in both philosophies and methods of care, you're looking at a medical component, a psychological component, and then a spiritual component. So that, and if you're in the hospital, you'll get a whole bunch of other disciplines, PT, OT, you know, whatever is needed, whatever discipline is needed, it's a team approach. We look at the whole patient, the body, the mind, the spirit. Family-centered. Families are very intricately involved in both philosophies. The two places where there's difference is that generally in hospice, curative treatment to try to eliminate the disease is not usually going to be provided, which means that doesn't mean that you're not getting treatment. What you're getting is treatment to focus on you being comfortable and having a high quality of life and keeping you from struggling to breathe and making sure that you're regular. That may seem like a really small thing, but trust me, it's an important part of your well-being. And then the other difference is that with hospice, you have to have that 6-month prognosis, but with palliative care, it can come in at any point in the trajectory. So coming soon, just briefly, we're going to be launching a palliative care program at Washington Hospital, and it will begin as an inpatient program. So that's just something, since you guys are all here and interested in this topic, that I just wanted to give you guys that information. There's not much more to say about it except that we're recognizing that it's something that we need, and that will be coming later this year. So, well, I thank you guys for coming out tonight to talk about a topic which is a difficult topic. So I really commend you. And again, remember, you guys are now ambassadors. So you have to go out and tell at least 2 other people that it's important to have this conversation. Okay? Thank you guys for coming.
Thank you, Michelle.
Yeah.